Well, good afternoon, everyone. My name is Sharinda Williams, and I want to welcome you to Georgia-HITEC's Keeping It Real Success Tips for Promoting Interoperability PY 2018 webinar. We ask that you connect with us via our website, www.ga-hitec.org, and on our Twitter page at Georgia-HITEC, #HIT Solutions. I would like to turn over this presentation to Carmen Hughes, Executive Director of Georgia-HITEC.
Thank you, Sharinda, and good afternoon to everyone. So glad that you all could make it. It looks like we have a great crowd. Hopefully everyone can hear me okay through the mic. We're excited about the webinar today to talk about Program Year 2018 for the Medicaid EHR Incentive Program. But before we get started, I think everyone knows who we are here at Georgia-HITEC, but just kind of an overview of who we are and how we represent the state in providing technical assistance for clinicians throughout the state and beyond, really. So we like to be known as the Georgia's Health IT Center for providing technical education and training, really around the redesign of the healthcare delivery, as we're going to talk about a little bit today, around the adoption of EHR technology and interoperable systems. So really our goal is to make sure that we're able to assist you with optimizing your patient information management as we transform really into this new value-based clinical models. As you all know, we're located at Morehouse School of Medicine in Atlanta, and we are with the National Center for Primary Care. We fall under the NCPC. So the NCPC is also going through a redesign, and so we are now really the Health IT division for the National Center for Primary Care. So I serve as the Executive Director for both Georgia-HITEC as well as the Healthcare Division or Health IT Division. So I will be your moderator for today's webinar. So we're excited about that, and I haven't been on a webinar in quite some time, a few months. So I'm excited to be here with you all today. I do want to mention we've got a great list of panelists on board for you. We've got some great experts and also a special guest. So before we get started, I just want to introduce our panelists for you. We've got Rudy Snyder, who's no stranger to you all. He's worked as a consultant with Georgia Tech and the Research Innovation Center for over 24 years. But in addition, he has, for the past 8 years, Rudy and Georgia Tech have been a significant partner with Georgia-HITEC in assisting clinicians and medical groups through the Medicaid EHR Incentive Program, informally meaningful use, now promoting interoperability. And during this webinar, Rudy is going to share strategies on how to meet challenging objectives and measures through the modified Stage 2 and Stage 3 of the Medicaid Incentive Program. And definitely no stranger to many of you on the call is Liz Hansen, who will examine the security risk assessments requirements and share some great audit preparation tips. Liz has been a consultant in the industry for over 30 years, or not quite 30, I think she told me to say, assisting providers with various healthcare arenas. Specifically, we have had the privilege to have Liz on our team and part of our Georgia-HITEC team since the inception of our program 9 years ago. And Liz is integrally involved with many of the HITEC education and outreach services that we provide to our members. So she's definitely no stranger to most of you on the call. And I'd also like to present our special guest, Francine Jackson, who's with DXC Technology. And you know DXC as the organization that reviews your applications and attestation applications. And Francine has firsthand experience looking at thousands of applications, so she's going to present sort of the do's and don'ts of the MAPIR application process. And she has been an outreach representative for DXC since 2016, but she's been with DXC much longer. And she promotes interoperability by providing education and outreach through conducting webinars and workshops. And we are both DXC and Georgia-HITEC partners with the Department of Community Health IT Division, which administers the Medicaid EHR Incentive Program here in the state of Georgia. So we're excited to have Francine to participate with us on this call, in this webinar today. So as you know, we're going to talk about several strategies I just mentioned for really reviewing the objectives and measures. Liz will talk about the risk assessment requirements, some tips about completing a successful application in the MAPIR system, share audit preparedness tips, and then we're going to discuss the benefits for participating in program year 2018. I will make a note here and a pause that this webinar is not for you to talk about your specific application, but if you have general questions that can be applied across everyone attending, then we'll certainly entertain those questions. If you have specific questions around your application, just send us a note and we'll contact you offline or outside of the webinar. So, that being said, let's kick off our webinar with our first polling question. So the question is, if my practice or clinician participates in the quality payment program, which you know is part of the MACRA Medicare side, does my attestation in that program satisfy my need to attest for the Medicaid EHR incentive program? I see 2 folks have already answered. It is open for everyone. We have, and you guys can see it, I'll just call them out. We've got 5% of 1 vote that says yes, it does satisfy. We have 15 or 75% saying no, and 4% are not sure. So we're glad you're on the call, or 20% I should say. And I think the presentation is coming back up. So Rudy, I'm going to turn it over to you, and if you could give us the right answer, and then we'll talk about some eligibility options.
Okay. Yeah, this is Rudy, and I'm real pleased to be in this call. The answer for at least eligible professionals would be no, in that you have to attest to both the Medicaid program and to the quality payment program separately, and you'd have to meet the eligibilities of each program. However, for the person that answered yes, actually, if you did that as an eligible hospital, it would be yes. So I don't know if there's any people looking for the Medicaid quality payment program for hospitals. That would be true, but not for eligible professionals. You actually have to attest separately. Okay, Carmen, did you want to add something on that?
Thanks, Rudy, and yes, I'm glad to see the majority of folks got that question correct. I do want to mention that as far as the eligible professional requirements for the Medicaid EHR incentive program is 30% Medicaid volume is required, and for the quality payment program, it's based on both the patient volume and the claims volume. So for patient volume, it's 200 patients, and claims volume for Medicare Part B reimbursement is $90,000. The other point I think is important to mention is that the Medicaid EHR incentive program, there's no penalty for non-participation, or if you choose not to participate, you obviously providers will, if they're eligible, will lose out on the $8,500 incentive payment. But for the quality payment program with the MACRA, there is a negative adjustment for non-participation, subject to a 5% penalty or negative adjustment for year 2020, and that adjustment will increase each year. So just important to note. So no, they don't satisfy, and they're 2 separate programs, and you have to have volume or other requirements to be an eligible professional or an eligible clinician. So Rudy, I'm going to turn it over to you to talk about some great strategies.
All right. Well, thank you, Carmen. I wanted to go ahead and just tell you at least what I thought my job was as far as helping Medicaid providers to achieve what used to be meaningful use is now promoting interoperability. I mean, when this program first started, one of the big problems was that the costs of healthcare were going up, very quickly against GDP. If you looked at it, it was almost a 45-degree slope of costs going up as a percentage of GDP. Since the implementation of meaningful use, we saw at least that level out, and the percentage of GDP kind of reached around 17.3% in 2011. However, it is still rising, and if you look at the year 2016, it's at 17.9%. So the growth has actually slowed as the implementation of electronic health records has taken hold. So that's a good sign, but we still are increasing, which means there's still quite a bit of work to do. And the reason that we need to do the promoting interoperability and sharing of information between eligible professionals and hospitals, as well as patients, to make sure that we have all the information we need to actually make the right prognosis. Just a couple other points. If you look at the cost of healthcare is over $10,000 per person in the United States. And other countries, really probably the nearest country to us is around $6,000 to $7,000 per person. And yet, when you look at the rankings, we're actually ranked number 53 in life expectancy, 54th in infant mortality, and then 32 in years of life lost. So it's showing that even though we're spending more money, we're still not getting the benefits of each dollar compared to some of the other countries. Another statistic that is not good for us is it's showing that medical errors, according to a Johns Hopkins study, and this is just a recent study back in, I believe it was 2016, is showing now that medical errors is now the third leading cause of death. And that's really disturbing. However, when you look at the things that they're trying to do through promoting interoperability and reducing medical errors through, say, clinical decision support and through e-prescribing and so forth, that these things are actually helping to reduce medical errors and eliminate the problems that they would have in healthcare of making these errors. When this first started back in 2010, 2011, roughly about 20% of ambulatory practices actually even had an EHR. So you can see the implementation of meaningful use / promoting interoperability has now increased that to where at over 75% of the practices actually have an EHR that is certified. So I think we've made quite a bit of progress. It shows that we're getting some of the benefits. The costs are coming out of the program, and that we need to still actually encourage providers to continue to do promoting operability, start sharing that information so we continue to make progress on both costs and quality of healthcare. So I also see, my job is going in there and really teaching the practices about the objectives. Tell them, what's the difference between stage 2, stage 3? Which one do they have to do? And what's even beyond stage 3? How are some of these objectives going to change? If they're doing the quality payment program and then you're also doing the Medicaid program, how do the objectives differ? Because they do. And so when you're doing a dashboard for the advancing care information, it may be different from what you're doing from the Medicaid. And so when you do your attestations, you have to understand the difference in the objectives. I also send updates to my clients. So as I'm receiving them from CMS, I'll forward those updates to my clients. Also, each year, CMS has actually come up with a comprehensive final rule that they kind of put everything together. They have it's on payment, quality, EHRs, just about everything CMS. And I try to take a look at that on an annual basis and make sure that there's some things in there that are not different from the prior year. And if they are, is to let my clients know that what's going to change for the new year. As I receive new FAQs, I'll go ahead and send those out. And anything I get from DCH and Morehouse, I send those updates out. Then also, any questions that I get, the way I try to, obviously if it's a simple question, if they're asking me, do I do stage 2, stage 3, I'll be able to answer them based on, where they're at. However, if it's a question that is more complicated, I'll usually answer that question as well as send them the supporting regulation material or information directly from the website so that if they were audited later, they would have that to show their auditor. I also stress the need for documentation to pass audits. If you look at when a Medicaid provider, they have 6 years to do their attestations, and the mandate is that I think 20% of the participants are to be audited each year. So if you attest for 6 years, you're probably going to be audited at least one of those years. So I make sure that my practices understand that they need to keep this documentation, and that it needs to be accessible, and it needs to support the data that they actually put into their attestation. I tell them also, hey, don't rely on the EHR. If you got your reports from the EHR, print those out or put them into an electronic copy. Don't count on coming back to the EHR and pulling that in case you get an audit later on. And don't rely on your IT people to do all this for you, because, who knows, you may change IT people and all your documentation may be gone. Then I'll also walk them through the process of the attestation, and if they have questions or problems, I'll help address those. I'll review the documentation if they have it available at the time when I visit their practice, and I'll stress that their documentation and the numbers that they actually have in their reports has to be the same as what they have in their MAPIR attestation. Okay, so if we go on to the next slide, I just wanted to stress some problem areas with most of the attestations I see, most of the the mistakes that practices may make. On the security risk assessment, it's just a couple of things that I see is that, one, they may actually lack having an asset list. Anything that has electronic protected health information on it needs to be on that asset list. And some companies, especially if they're doing the ONC security risk assessment, they don't notice that there's a tab on there to list all those assets. And so I try to make them aware of that, make sure they do each part. Also, when practices answer yes, no to questions, and they just don't put a lot of thought into their plans to correct the issue. And so I try to stress that they need to do this, that if they're answering no to a question, that they're not in compliance, that they actually have to put in there a plan of how to get back into compliance. And then I also make sure that they date the analysis and they keep it with their documentation. Some other problems, so I want to make sure that they, as far as the answering yes to clinical decision support, that they collect the screenshots, and that, for instance, for clinical decision support as well as drug, and drug allergy. Some of the practices also forget to collect the documentation that they actually need about their registries. So if they have any emails, documentation, the testing, or actually the transfer of data to the public health objective, they actually have to have that as part of their documentation in case they're audited. And then I also stress that they need to print out their encounters that supports their eligibility, and try to organize it so that, when the auditors take a look at it, they can understand the data, that it's just not a bunch of encounters and then you have to go through it like 20 times to figure out the numbers that you actually have on your patient volume calculator. Sometimes, practices, they get confused about the eligibility and the use of the patient volume calculator. And every year I get asked the question if the reporting period needs to be the same as the eligibility period. And that's no. And that you're establishing eligibility first, which can come from the prior calendar year as well as from within 12 months of the attestation date. But that is different than the actual reporting period, the 90-day reporting period that you would use to actually meet the objectives. And then also I need to probably every year explain to one practice or another the difference between doing a group calculator versus doing an individual calculator. So those are no problems, but you know, it's just some of the issues they may have since they only do this on an annual basis. And then I do stress one of the biggest thing is obviously keeping copies of all their documentation, because like I said, they're going to get audited. You know, do not rely on the EHR to have your legacy reports. Don't rely on your IT person to have your reports. And really, I think it's best if you have either a binder with all the documentation in it, or if you decide that you want to have an electronic copy of it in PDF format, for instance, that if it's on a computer or server, make sure that you are also doing backups on those, because computers crash, you know, personnel change, and things get lost. All right. Well, that's all I have. I guess I'll turn it over to the next person. Oh, I guess we have a polling question, right?
Great. Thanks so much.
Okay.
Those are great strategies and tips, and certainly sharing the experiences that you have seen over the years with attestation applications. So thank you very much. So yes, we do have a new polling question up. So the question is, we have completed our security risk assessment. Is that right? We have completed our practice security risk assessments for 2018. Have you? So that's a yes, you have. No, you haven't. What the heck is a SRA? Or you choose not to vote, or not applicable. And then I'll turn it over to Liz, because Liz will, for those all of you who have said no, which is just a few at this point, she'll certainly give you some pointers on how to get ready for this program year 2018. All right, so looks like we have about 5 say yes, 3 no, and then the rest are not sure. So the poll is closed. Thank you, Sharinda. Liz, that being said, I'm going to turn it over to you to talk about security risk assessments.
Thank you, Carmen. Wait for the screen to reset for us. Remember that the security risk assessment is a HIPAA requirement. So it's not just a requirement of promoting interoperability and those measures. It is a law that you have to do a security risk assessment every year. So the fact that you have to do it to meet your measures for promoting interoperability just gives you, what it actually does is gives you an avenue to have some assistance with it from the Georgia HITEC and our staff's perspective. But it's very important that you do this for both reasons, both to meet promoting interoperability and to meet the HIPAA requirement. So we do recommend that you perform the security risk assessment prior to attestation. But truly, we'd like for you to do it within your attestation period, within the time of your eligibility when you're doing those 90 days for submission, or prior to that during that calendar year. And one of the reasons we recommend that is that many practices will use the last 90 days as their reporting period, and then think, okay, I just have to do it before I attest. But if you were to do it in 2019, you wouldn't be meeting the HIPAA requirement to do an annual risk assessment. So to be safe and to get it done for both requirements, then we suggest you do it prior to in that calendar year or during your reporting period. Please make sure that you give it a new name every year and that you use revision levels. I say that it seems like common sense, but I say that because oftentimes, especially if you're using the ONC version of the security risk assessment, you may bring that one up to the screen and start making your changes and then save it, and you will have updated the one you needed for an audit if one occurred. So please make sure that you rename it and resave it. And then as you go in, if you go in and make changes during the year because you've changed an EHR or you've changed your security officer, then go in and update that as those changes occur and then put a new version level on it. Make sure that you also put a date on it. Put the practice name and a date inside in the title, and put that date inside of that security risk assessment, perhaps on your asset page, or perhaps on that first question where you talk about that you do have a security risk assessment. But put a date somewhere in there so they know that you actually did it in 2018. Please remember that you must have a mitigation plan and the dates that you plan to complete that mitigation. We have had folks in the past that were failed on an audit because they didn't have a mitigation plan. And some of these people actually paid thousands of dollars to have an outside consultant do their risk assessment, but because they were missing that one page with a mitigation plan and the dates that go with it, they failed the audit. Now, the good news is they were able to provide that, and they ended up not failing the audit on multiple occasions. But if you didn't do the work, you can't provide the plan. So please make sure that you get all of those done. Rudy did mention that you have to have an asset inventory. And in this inventory, you can identify all the systems where EPHI is stored, received, maintained, or transmitted. And you're also going to list any of the software that may impact EPHI. So making the inventory may be hard. Many of you have your IT companies keeping the inventory, and you can say, see attached inventory list, but you still have to go into that inventory and denote where those assets have EPHI. Most assessments will address the 3 safeguards. They may not call them the 3 safeguards. The ONC version does not call them the 3 safeguards, but it does address administrative, physical, and technical areas for your risk assessment. Don't just limit your answers to what your EHR system can do and does, because your EHR does not show what your administrative policies and procedures are. It doesn't address the other doesn't address the physical components of your office, nor does it address things like your copier, for example, which typically will have EPHI. So don't just limit it to your EHR. Address your entire office environment and the areas that are administrative policies and procedure, physical facility and systems, hardware, if you will, and then the technical aspect, which we refer to as with software. Remember that you have to date that security risk assessment, and you have to keep it for 6 years. Remember, if it's covered on the security risk assessment, you should have a policy and a procedure for it in your HIPAA manual. And that year after year, this surprises people often in our practices, but if it's on the security risk assessment, that implies you should have a policy and procedure to cover it. Now, just a few areas that you want to make sure that you do have covered. You want to make sure that you go over your security measures, and those are typically answers when you go through your assessment. You want to make sure that it shows your threats and where you're vulnerable, where the likelihood of a threat may occur, the potential impact of that threat occurrence, and then your final report and mitigation plan, or your action plan, if you will, of how you are going to resolve any areas that you are at risk and by what date you'd like to have those resolved. Now, technically, you don't have to have everything resolved by the end of your submission time, if you will, but just understand, if you were to be audited by HIPAA and you didn't have those resolved, that would be an issue for you. And truly would show willful neglect, because you know you're supposed to mitigate any of those issues. So please make sure you make the mitigation plan and you complete the mitigation plan. And then many folks say, well, how do we do this? Well, you've got some options. You don't have to hire a consultant or a service, but you can hire a consultant or service. Remember, if you have an IT company that is performing this for you, perhaps, and many IT companies do provide this service, that doesn't necessarily mean they know what your policies and procedures are. So if an IT company is doing your security risk assessment, then you need to talk with them about the policies and procedures you have to support that risk assessment. And they may not be aware of it. And if they are not, they cannot complete your risk assessment effectively. Conduct a risk assessment internally. You can do that using the CMS provided tool, which you can get on the healthit.gov site, or you could use the ONC provided tool, which is a spreadsheet. I know it looks very complicated, and some folks aren't comfortable with working with the macros, but we've had a lot of success with using that, and we have passed many audits using that tool properly. So make sure if you use the CMS tool that you ensure the mitigation plan with the dates. There is a remediation tab, and I've seen many people miss that remediation tab. It's on every question within that assessment, and many folks don't realize that there's a tab that says remediation, and if you don't fill that out, you don't get your mitigation plan on the final report. And we can give you some individual advice on how to do that, at least walk you through how you complete it. And we strongly recommend you take advantage of that if you're uncomfortable with it. Of course, if you can afford to hire a consultant, by all means do so. But one way or another, get it done. So I believe that takes us to our next polling question. And Carmen, I'll hand it back to you.
Awesome. Thank you, Liz. Great tips. We appreciate it. And I do see some notes in the chat box, so we'll follow up those at the end. But I think there's some new information that's out. So thanks so much, Liz. So yes, we have our next polling question is the verification of use letter is one of the MAPIR upload requirements in program year 2018 for the Medicaid EHR incentive program. Do you all think that's true or false? And again, this is the verification of use letter related to your EHR. Okay, so we have fewer people answer this polling question, so great opportunity for education and learning. We have about 60, well, that's split, 55% saying true and 45% saying false, so 6-5. So thank you, Sharinda. We've closed the poll. And I will turn it over to our special guest, Francine Jackson of DXC, to tell us the correct answer and provide some clarification for us. Francine?
Thank you, Carmen. Thank you, Carmen. And the verification of use letter as of program year 2018 is no longer a requirement upload. Only thing that you will need from the verification of use letter is your certification number. One of the things that we like to do is to let providers know exactly how to eliminate errors when they're putting in their MAPIR application or doing any uploads. And what I have composed is a few MAPIR application do's. One of the first things that you must do before you start your application, you would need to check the demographic information in GAMIS to see if it matches the CMS National Level Registry. And what I mean by that is the demographic information such as the NPI number, tax ID number, street address. That information is very important that it matches in the CMS identical to GAMIS. And to give you a perfect example, if you spell the word street, S-T-R-E-E-T, in GAMIS as your demographics, that information will need to be the same on the CMS website. If by any chance that information is correct on the CMS and not correct in GAMIS, then your first thing what you must do is contact DXC Technology, and what we'll do is route you over to our provider enrollment department. Now, vice versa, if that information is correct in GAMIS and it's not correct on the CMS side, then you want to make sure that you go into the National Level Registry to correct that information. The next area I like to talk about is the detailed encounter report. There are a few areas that you must include on this report, and they are the date of service, provider's name, unique patient ID or patient name, as well as the type of insurance. Now, on your detailed encounter report, you want to make sure that you do not have any duplicates on your report, because keep in mind it's one patient per encounter per day. You also want to match the 90-day reporting period to the patient volume calculator and what's in MAPIR. Those dates need to be the same. Also, you want to check the number of patient encounters against the patient volume on the PVC. For example, if you have 39 well care on your patient volume calculator, then you would have 39 well care on your detailed encounter report as well. You want to save the detailed encounter report in an Excel format. And last, what you would need to do is to upload that report into MAPIR. Now, sometimes you may have an error. If you can't upload into MAPIR, feel free to contact DXC Technology, and we'll assist you with getting that report uploaded. The next area is your patient volume calculator. Before you place the provider on the calculator, you need to make sure that the provider is eligible, and it kind of goes back over into the demographic information. You also want to download the correct PVC from the Department of Community Health's website. Now, we have had some providers that may have an issue downloading. If in that case that happens, then you'll want to again reach out to DXC Technology, and we can forward you over a blank PVC. On your patient volume calculator, you want to make sure that you use the previous year or your current year patient volume. Also, one important thing that we have seen several providers do is to input the incorrect address on the PVC. So make sure that you check the provider that you're attesting for, and I mean like the location, the letter number at the end. Make sure that that information is correct. And those of you who are attesting as a group, you will want to put yes or no on your PVC next to the provider name that's seeking a payment for a group. Last, what you would need to do is to proofread that PVC. A lot of times we have providers that rush when it comes down to the deadline, and they upload the PVC and it has a lot of incorrect information on it. So you want to make sure that you read that information before uploading it into MAPIR. And then we answer this question for the verification of use letter, no longer again as a MAPIR requirement. And you want to make sure that you can verify, make sure the information, the certification number is correct before you enter it into your MAPIR application. And that's all I have, and I'll turn it over to the next presenter.
Awesome. Thank you so much, Francine. We appreciate that, and we know that you've seen hundreds of applications, so knowing that your information is extremely helpful, I appreciate it. So, Liz, I'm going to turn it back over to you if you want to talk about some audit preparedness tips. I think that would be great.
Thank you, Carmen. And I did want to just say we've had several questions asking what MAPIR was. That stands for the Medical Assistance Provider Incentive Repository. And yes, it is only for Medicaid participants. So when we talk about audit preparedness, we need to make sure that you know what the documentation is that has to be uploaded, that you upload that documentation, and then you save it. This includes your patient volume calculator, your EHR Chapel certification number for the period during your attestation, your detailed encounter reports, and please have those summarized so that the folks looking through and reviewing your information can quickly see the numbers and match them on your patient volume calculator. It'll also make it easier for you once they're sorted. You must have your security risk assessment with a mitigation plan, dates for mitigation, practice name and date of assessment uploaded and saved for audit preparedness. Promoting interoperability report. Some of you still have that called meaningful use on your systems. So it's that meaningful use or promoting interoperability report. Your clinical quality measures report. The screenshots for your yes-no measures saved as a PDF. Remember that when you upload, we can only upload certain formats in Excel and PDFs, so you should already have these saved that way. You need to have proof of your 5 clinical decision support rules that relate to at least 4 of your clinical quality measures, and that typically requires taking a screenshot. Again, these screenshots should be taken during the time period that you're doing your report. So if you're using a 90-day period for your report, then your clinical decision support rules should be taken during that time period. We don't want you taking them in 2019 and submitting them for a 2018 submission period. You do want to make sure you have a screenshot of your drug allergy interaction checks. And I may have added this on my own, but I like to go ahead and make folks get a screenshot of the drug formulary. And then your GRITS utilization screen. You may have a screenshot of the transaction. As Rudy mentioned, you may have a letter or some emails that reflect that you're in the test process. save all that documentation. Make sure that you have documentation for your exclusions or your proof of activity with any other registries. And again, you may just take screenshots, you may save emails and have those saved as a PDF. Remember that you need exclusion documentation for any measure that you exclude. I know that some of you have utilized the ability to exclude health information exchange, that measure, if you're less than 100. So you need to make sure that you document why you took that exclusion or what made you eligible for that exclusion. You don't just check a exclusion and not have proof or documentation why if you get audited. Also, make sure that you have any FAQs that impact your exclusions or your attestation. And I believe Rudy also spoke about this. I know just recently we had some issues with one of the EHRs that found after the fact that the reports were not correct for 2017. And many of you were scrambling or concerned because you were getting letters from that emails from the EHR telling you that this was an issue and that you had to report it. And so there are some, there is an FAQ that spells out that the intention is not to penalize anyone if there was an issue with their EHR, but we need to have the documentation saved where the EHR is informing you of the issue. And we also recommend you keep those FAQs so you've got the proof of making a good, strong decision based on the FAQs and the rules. So that's all I had about those, and now I think we were just going to recap some benefits. Carmen?
Yeah, that sounds great. And please keep your questions coming in. And want to ask the panelists if they could give one, maybe two benefits you think for entering for participating in the program, because entering, you would have had to enter by 2016 in order to continue through 2021. If you skip a year, again, there's no penalty for the program. But I want to just check with the panelists and see if they had some benefits they want to share. And I'll start with, we'll kind of go in order with Rudy.
Yeah, I guess I just see as the benefits is really helping healthcare as a whole, is that where we're trying to progress and help reduce our costs in healthcare, as well as improve the quality. By only doing this and sharing information through the Promoting Interoperability program, would we be able to do this? We couldn't do it with paper charts. There's just no way we'd be able to do it that way. So I think continuing on the path we're on is a big benefit to America as a whole in healthcare, and is going to help us get to the point where we're going to be able to reduce errors. We're going to have high quality healthcare, and our costs are going to go down.
Awesome, Rudy, and I couldn't agree with you more. Liz, on your end?
Yes, first I've got to say, well, there's money involved, right? So on the Medicaid side, you can earn $8,500 for each provider that you meet the requirements and submit for. So that's got to be seen as a positive. The other thing, and perhaps the most important thing that I see, is that the Promoting Interoperability, what used to be Meaningful Use, is pushing everyone to be able to do health information exchange. And, Promoting Interoperability really was the goal all along. Even when it was named Meaningful Use, what we wanted to do was to reach a point where we could exchange patient information anytime, anywhere that it is needed throughout this country. And I just needed to bring up that this was seen in great effect just last month when North Carolina had all of the issues with the hurricane, and so many people went to South Carolina to get away from the flooding and the results of the hurricane. And the South Carolina State Health Information Exchange was able to connect with the North Carolina Health Information Exchange and get the patient data for those folks that had come down temporarily. So there's many real life stories about how interoperability has changed and saved lives. And so there is a great light at the end of this tunnel. and there's a great reason for doing it, and let's just keep pushing it. I know the HIE part is hard, but let's keep pushing it because the end results are life-saving.
Thanks so much, Liz. And great points, and certainly use cases are all around. And I've read some, and we've tried to share some, so that's perfect information. I do want to add to that. You mentioned the Health Information Exchange. So Georgia Health Connect is one of the services under Georgia HITEC, or the Health IT Division, and we do have some funding to help support the Health Information Exchange. So not only do we support the Medicaid EHR incentive program attestations for technical assistance, as well as the Quality Payment Program technical assistance, but in addition, as part of the Health IT Division, we have the Health Information Exchange, and all of that is funded either through federal or local dollars. So we want to make sure that we provide information to you all in a cost-effective manner so that you can take advantage of and be prepared for the different programs and the various services aligned with those. So Francine, I'm going to ask you what you think, from sitting in, and from your perspective, the benefits are for the program.
Thank you, Carmen. One of the free benefits that I feel that's good for this program, that it's all free money, and providers just have to follow the program rules and guidelines. And most important thing of it all is that they're not entering this process alone, because they have all of our partners that are here to assist them.
Awesome, and we do work very closely together, again, through the under the leadership of the DCH, Department of Community Health, Health IT Division, share resources for supporting the Georgia providers in this initiative and effort. So thank you for bringing that to the attention, to the point of DCH has monthly workshops. And so you may hopefully have seen some information around the workshops throughout the state. DCH brings the partners together, and we travel throughout the state. I think the next one is coming up, maybe on our list, on the go, which will be coming up shortly. And I believe it's at the Cobb Douglas Public Health District. So please take advantage of the on-the-ground, boots-on-the-ground services that are available for technical assistance with the DCH partners. So we panelists have actually left some time for questions. And I've seen some questions come through and some answers come through, so that's great. I appreciate it. From a high-tech perspective, Selena Williams is our program manager specifically for this project, so feel free to contact her with any questions, any feedback, any support that you might need, and we'll allocate those resources to you. If you're not already on our mailing list, and I'm assuming you are because you're on the call, but if you're not receiving some of the information, we ask you to let us know through our info support at georgiahitech.org and let us know. And we also have a call center that's available to everyone each day from 8 to 5, I believe. So, Sharinda, do you want me to turn it back over to you for any questions that have come through the chat box that are not yet answered?
Sure, I can go ahead and take those over, Carmen. We had a couple. Hey, hello, everyone. Thank you so much for joining us. I want to start with Karen's question. Is this webinar solely, I guess the content for this webinar solely for Medicaid reporting?
This is Carmen. I'll take that on. And yes, and I did look at the title, and it says promoting interoperability. And so we know that term now is used for both programs. Our intention was for this webinar solely for the Medicaid EHR incentive program. Payment year 2018 alludes to the Medicaid program, but this one's specifically for Medicaid in this particular. Now, we'll mention that we do have virtual office hours for the Quality Payment Program under MAPIR and I'm going to think about this, every second Tuesday of the month from 12 to noon, where we actually focus specifically, thank you, Phoebe, the second Tuesday of every month where we focus specifically on the Medicaid EHR, the quality payment program for Medicare.
Thank you so much, Carmen. And we got a question earlier. How can you get more portal usage when most of your patients are senior citizens?
Okay. So I know that this is a struggle, especially when you have older patients that don't use the computer like many of us do. And so we do have some recommendations. One of those is if you have an employee that can spend a few hours a day taking these patients to an area that is secluded or is away from the hearing of other patients, and then you could sit down with them and work through them about how to sign on. We've even had them go ahead and set them up a Gmail account and sign on. Many of the practices that I work with can't really afford to do that, but some of them have been able to work with a local community college or university that has healthcare programs and have been able to get interns to come into their office and to have the interns work with these older patients in setting up their portal. The good thing is when they do this, they help them set up the portal, they go in and do download and transmit, and they send a secure message, which actually gives you fulfills three different measures. So you get a lot of mileage out of that. If they are in an intern program, they will often work at no charge because they're getting course credit for it, or for minimum wage, if you will. We do caution you if you are going to use an intern. I do have to say, these young folks are often, they may not be great with their parents, but they are often very good with the older generation that needs the help. They are often more patient than you would ever imagine, but they are also lovers of social media. So it's very important you get that non-disclosure or confidentiality agreement signed, that you have them go through the HIPAA manual, and that they do HIPAA training. And then also give them a little speech about you can't talk about any of the patients in any way, shape, or form on social media or out in public. But we have found that to be a successful method for improving that score.
This is Rudy. I just wanted to add to that a little bit in that when ONC wrote this requirement too, they did purposely keep what they thought, and I'm not going to say it's applicable in all areas, but they purposely kept that number down low at 5%, so that they felt that most practices would be able to get it. However, some of the practices that I work with, what they also do is that they at least promote the patient portal. They'll send out messages to, emails, whatever, text messages, whatever, to promote the patient portal and the use of the patient portal. So, if the participant is technology averse, I don't know if you'll ever really get them on there. But at least the ones that deal with technology, either on their devices, their phones, their computers, whatever, hopefully you can get those people to participate.
And to add to that, Rudy, we found that if the providers tell their patients to use the portal, it is a little more effective. You might have your providers give them the instruction sheet and maybe even put their initials on it and hand it to the patient and ask them to log into the patient into the portal within the next 24 hours. And we have had some success with that.
Thank you so much. I think we have time for one more quick question. It looks like in the chat box it was asked, is the new calculator ready for use?
Yes.
That was perfect. So again, I wanted to reiterate.
Sharonda, I'm sorry. And Phoebe just put it out there where it's available. We were going to let you know. So it is available, as well as the 2018 attestation application is available. So feel free to go to the DCH website. Phoebe just posted in the chat box, as well as, again, feel free to contact GA-HITEC for additional support regarding your 2018 application.
Okay, and I just wanted to go through and let you all know that all this information will be provided later on, is at a later date on the www.georgia-hitec.org site, where you can see an actual video of the presentation, see the slides, and get some information about the background of the actual presentation. And also, if you have any additional questions that we did not address, you can feel free to email support@georgia-hitec.org. And we also have some upcoming events. If you can see on here, DCH Meaningful PI Workshop at Cobb Douglas Health Department, November 1st, 2018. Fall Medicaid Fair Conference, Cobb Galleria, November 7th, 2018. And the Georgia Academy of Family Practice Physician Conference in Stone Mountain, Georgia, is November 8th through the 9th. We want to thank you so much for joining us and getting your questions out there. We have some resources here that will also be on the website if you need to get a little bit more information or anything like that. Again, thank you so much for joining us, and you will have a great night.